Okay, if you wouldn't mind introducing yourself.
Hi, my name is Tim Sefton. I'm an NHS general practitioner. I'm also a principal partner in an NHS general practice near Bristol, and I'm also a board member on the Bath and North East Somerset Clinical Commissioning Group, where my areas of special interest are planned and emergency care.
Okay, thank you. So Tim, as your daily life as a general practitioner, what are some of the common ethical decisions that you might regularly make?
So one area I'm especially interested in is the whole frailty agenda. There's a growing feeling that the NHS will need to be very clear in how we deal with an aging population with multiple comorbidities and the potential to spend huge amounts on the last few months of people's lives. This proves very difficult when we are trying to balance out what people would like for their older years. It's important to be brave enough to have difficult and often painful discussions. As a GP, I'm very invested in people. I'm often looking after people that I've known for 20 years in my role as a GP. And these can be very challenging discussions for the clinician and the family and the patient.
Okay, thank you. How do you think that the recent coronavirus pandemic has affected your daily routine as a general practitioner?
Oh, it's been absolutely career defining. We have never seen anything like it. The closest I've experienced to it was the early stages of the HIV pandemic in Southern Africa. Been high levels of planning, a lot of patient-led anxieties which have needed to be addressed. And in terms of the impact on my daily practice, it's entirely changed the way I see patients.
Okay, how do you think it might affect hospitals that are dealing with it, so in a different way to how it might affect a general practice?
So there are 100,000 acute beds available. That is for urgent and emergency care in the NHS in England today. We're trying to clear out 30,000 of those. The immediate impact is that many older, frail people who are perhaps medically fit to be discharged are being clearly instructed to leave hospital at once in order to make place for an expected tsunami of profound respiratory disease.
Okay, thank you. What are some of the ethical decisions that you think might have to be made in a hospital environment in regards to this pandemic?
There are going to be some very blunt decisions, starting with general practice. I'm going to be seeing older, frail people with multiple other illnesses who will have real respiratory disease, perhaps pneumonia. And these are all people I would previously have had no hesitation in calling an ambulance for, speaking to my local acute provider and getting them hospitalized. It is quite probable that we're going to be looking after these people in the community, and that is just, as it were, palliating them. That means providing them with medications to make sure that they are relatively comfortable and that they are able to deal with their levels of breathlessness. This is going to be a profound change for all of us.
Okay, but specifically relating to the hospital environment, I know that you don't work in one yourself.
So at the front door of any accident and emergency, they're going to be making brutal decisions. Are you going to be admitted to intensive care, or are you going to be admitted? We've only got a limited number of spaces. Then they're going to be much wider ramifications. They're going to be really ill people who need important operations, specifically, for example, treatments relating to a tumour or any other aggressive, life-limiting form of an illness, who will have these treatments withheld specifically to create more space for respiratory illness.
And how do you think that medical professionals will be rationalising these decisions that are going to have to be made, whether patient A comes into A&E or whether patient B can be admitted? How do you think that that's going to be dealt with?
It's going to be very difficult to do that. because for many of us it'll go against years of clinical judgment and planning, and people that we would normally have expected. Let's, for example, if you are elderly and you fracture your, if you have a fracture of your actual femur bone, this is a very serious illness, and normally you would be expected to have an operation within 24 hours. We're going to be having very real plans to keep these people in the community, understanding that we just don't have the theatre space. The only way that we're going to be able to deal with this is for there to be a wide range of support for clinicians at the front line to be able to have very serious discussions with the patients and their wider families.
Okay, thank you very much for talking to me about this.